Good morning. We're going to go ahead and get started. Welcome to the second day of the NACFC, and for the fourth year in a row, thank you for coming to see Seeing More Than CF. Sorry, this is the third year in a row. Next year is the fourth year in a row. There it goes. This is our disclaimer. Dawn and my name is Kim Villari. I'm with the Children's Hospital of Alabama. Dawn is with Nemours in Delaware, and we are your moderators. This session will provide information on how the respiratory care of people with cystic fibrosis may be impacted by comorbidities or other concerns such as diabetes, mental wellness, lung transplant, and those that are not eligible for modulator therapy. Each presentation will be built around one of the above comorbidities and concerns. There will be discussions regarding risk factors, treatment strategies, resources, disease prevention, health promotion efforts for people with cystic fibrosis. And with it also being Respiratory Care Week, I just wanted to say this little quote that I found. As long as there's breath in our lungs, our story is being written. So happy Respiratory Care Week. Our objectives: understand how disease, comorbidities, and other concerns may impact the respiratory care of people with cystic fibrosis. Describe how mental health can impact the overall care of people with cystic fibrosis. Discuss risk factors, treatment strategies, resources, disease prevention, health promotion. Then
So I have the pleasure of introducing our first speaker, but first I'd just like to remind everyone that if you have questions, and it doesn't look like, oh, we do have a microphone here and there if you want to ask questions in person, but feel free to use the chat. We will be monitoring that while the sessions are ongoing. So again, I have the pleasure of introducing Dr. Anna Georgiopoulos. Is a consulting psychiatrist for Massachusetts General Hospital CF Center and is a part-time associate professor of psychiatry at Harvard Medical Center. She's played a key role in developing and implementing international guidelines for screening and treating depression and anxiety in people with CF and their caregivers, and the CF Foundation Palliative Care Guidelines. She chairs the education and training subgroup of the CF Foundation Mental Health Advisory Committee and serves on the European CF Society Mental Health Working Group, TDN Sexual Health, Reproduction and Gender Research Working Group, and TDN Mental Health Research Working Group. A member of the CF Foundation Data Safety Monitoring Board, Dr. Georgiopoulos leads clinical trials in CF mental health and palliative care, and she was the recipient of the 2018 Carolyn and C. Richard Mattingly Leadership in Mental Health Care Award from the CF Foundation. Please welcome Dr. Georgiopoulos.
Thanks so much. Thanks so much for having me today, and I think this is really fabulous to have this interdisciplinary session. I'm pleased to kick it off. These are my disclosures. So really today what I wanted to talk about is the connection between physical and mental health. And this is a quote from our CF-CBT manual. This is our CF-specific cognitive behavioral therapy manual that was developed in partnership with adults with CF. And this is what one of the adults with CF said: it becomes like a cycle. It's easy for me to get really emotionally down about being sick. And then I feel like because of that, I'm not trying as hard to get better, which in turn makes me feel worse, which makes me feel mentally worse. It really becomes like a snowball effect. It's definitely very connected, the emotional health and the physical health. And I'm sure all of you have seen a situation like that with how that cycle can really snowball. So I'm going to be talking about each of these pieces in this little circle here: the mental health, lung health, physical activity, and relationships around inflammation and adherence and avoidance. So we know that depression and anxiety is common in people with CF. It's 2 to 3 times the rate in the general population among adolescents and adults, as well as caregivers. And this has implications for physical health outcomes. So in looking at this, the TIDE study, which was a large epidemiologic study in 9 countries of depression and anxiety, Dr. Schechter took the U.S. population from that study, which was over 1,000 people, and looked over time at, based on that one screening for depression or anxiety, what was the risk of pulmonary exacerbations and what was the risk of mortality over time. And he found increased pulmonary exacerbations in the next 5 years with an elevated depression screen. And again, with that one elevated depression screen, a doubling of risk of dying in the next 5 years. So, of course, depression has a big influence on quality of life, but it also impacts physical health outcomes. And this is another example of a study that shows that interrelationship between mental health and physical health outcomes. This was a study by Dave Barker and Alexandra Quittner looking at children with CF whose parents had depression symptoms. And those, in those cases, the parents were less adherence with enzymes for their kids. And then in turn, the kids who had trouble with enzymes had poorer weight gain over the next 3 months. So again, we see that link between mental health mediated by poorer adherence, leading here to poorer GI nutrition outcomes. And so again, what may connect that relationship? So this is a great study by Kristen Riekert and colleagues looking at what are the factors that contribute to the influence of depression on poor ability to sustain daily care. And in this case, they found that medication beliefs mediated that relationship. So higher depressive symptoms were associated with less positive beliefs about medication. And again, that was then associated with less adherence, which makes sense. If you don't believe the medicine's likely to be helpful, if you're feeling fatalistic and hopeless about it, then you're probably not going to bother to take it, and it's not going to be able to do its job. So what are some other factors that might mediate that relationship? Well, if you think about the symptoms of depression, low energy, poor concentration, feeling physically slowed down, could make it difficult to get to your appointments, to take your medications. And in some case, it really is a form of passive suicidality, right? Like, why bother taking care of myself? What's the point? I'm a burden anyway, right? So another way that depression impacts physical health is through inflammation. And we know that there is a bidirectional link between depression and inflammation. So depression in both general populations and chronic illness populations is strongly linked to systemic inflammation. So we see high CRP levels, IL-1 beta, IL-6, and TNF-alpha levels. If you have high levels there peripherally, then that predicts future depression. And in turn, baseline depression predicts increased inflammation over time. And physical activity is a place where we can intervene in that cycle. So regular moderate intensity exercise lowers markers of chronic inflammation, improves immune surveillance, enhances adaptive immune responses in aging populations, which is so important now as people with CF are getting older. And there's lots of work going on understanding the mechanisms, which may include myokine upregulation that can affect the way immune cells function. So in the general population, again, there are many studies emerging about how physical activity may impact depression. This is a systematic review and meta-analysis that came out recently, looking at 9 randomized controlled trials, and there was greater improvement in depression severity in the intervention group when the intervention is physical activity. Long-term exercise interventions were more effective than short-term ones. That makes sense. And in this meta-analysis, high-intensity aerobic exercise had the greatest efficacy, followed by high-intensity resistance training. And high-intensity interval training was comparatively less effective. And this is a study that, so that was in the adult population. This is a study in children and adolescents, doing a network meta-analysis of 17 studies, looking at different types of exercise. And what we see here is the most effective type was resistance training, actually, weightlifting, right? So a lot of times people say, I want to get moving again, and they'll start, I'm going to walk, or I'm going to go on treadmill. Those are really important things, but also that resistance training, we know it's good for bone health. We know it's good for depression as well. Okay, so getting closer and closer to CF here, there's actually some work on psychological distress in people with COPD, adults with COPD and physical activity, 21 randomized controlled trials in this meta-analysis, and they saw significant improvements in anxiety, depression, emotion regulation, and a feeling of self-efficacy, right? Which we know that self-efficacy, that feeling of I can kind of deal with what comes up, that is highly tied to future depression as well, so that's a really important outcome to be looking at. So what about modulators? So this is a study of adults with CF, 82% of whom were taking a modulator. And people with CF who were taking modulators, we would think, okay, it's going to be easier to exercise, but actually they more often reported lack of time as a top barrier to exercise, right? So as they're able to do more and more, it's like, where does the time for exercise fit into that? 35% rated fatigue as a top barrier to exercise, and that was irregardless of which group, whether people were on modulators or not. But I wanted to point out that 12% rated depression and anxiety as a top barrier to exercise, and again, that was similar whether people were taking modulators or weren't. So again, most felt that their physical fitness had improved since they started a modulator. Most were more confident in their ability to participate in sports or exercise. About half felt more motivated to participate. So for most of these things, starting the modulator improved their outcomes. But I wanted to point out here the concerns about weight and the concerns about depression and anxiety, where we see a more mixed picture in terms of the barriers to exercising. Weight gain with modulators is something that, can affect people's ability to stick with the modulators, to even want to be taking them at all. Can certainly affect how people feel about their bodies, which can then have an influence on their mood and anxiety. There is more and more work starting to happen now about body image and disordered eating in people with CF. And so this is a study of healthcare providers asking, are these important topics? Are you comfortable talking about them? Are you screening for them? And of course, more people felt they were important than are actually comfortable talking about them or screening for them. But I wanted to point out with these arrows a few areas that are really CF-specific kinds of disordered eating, right? Adherence to pancreatic enzymes, right? If I stop my enzymes, maybe I'll lose some weight. Adherence to insulin, right? So again, if I stop taking my insulin or manipulate my insulin, then I may lose weight. For people with CF-related diabetes, and then excessive exercise also is something to keep an eye on, as people have more energy but also may not be feeling great about how they look. So as I go through, I'd like to point out some of our CF Foundation Mental Health Advisory Committee resources, which you can obtain on my.cff.org in the resource library. This is the Tips for CF Care Teams conversation about body image. And there's a great position paper on this topic as well, highlighting how body image concerns may be evolving, thinking about weight stigma, and how we can use weight-neutral approaches and constructive language, especially, but not only, in people with CF who have struggled with body image, disordered eating, and weight stigma. And I guess my point of not exclusively is we don't necessarily know who's struggled with their body image or feeling weight stigma, right? Because they may be up to a normal weight now with a modulator, but really be feeling intensely that kind of change in image from how they used to look. So here's just one idea of how you could broach that topic. A lot of people on modulators are experiencing changes to their bodies, have different or conflicting feelings about it. What has it been like for you? Okay, and so thinking again about the influence of modulators on mental health, here we see that as we know, this is from the WellMe survey, which is a large survey of well-being in a variety of domains of people with CF. And people who were taking Trikafta or ETI reported improvements in many domains of well-being, right? Health, quality of life, physical well-being, experience of care. But you see where it starts to become a little more mixed. The red indicates, that an area of well-being worsened after taking a modulator, and the blue indicates that it improved. And you see more of this pink and red in the mental well-being category. And when we break that down, again, the blue is improvement and the red is worsening. And you can see that all these different aspects of mental health, anxiety, agitation or irritability, cognition, feelings of stress, body image, depression, sleeping, all of those things tended to get worse more than they tended to get better. Now, this was also occurring, the survey, around the time of COVID, so we don't know for sure that that this had to do with a direct impact of modulators, right? But it's important to think about that not everything is all positive after you have an improvement in your health, even though you might think that it should be. However, a sense of optimism definitely improved more than it worsened, right? And so that's really important because hope and optimism have a positive impact on physical health and longevity. Okay, so again, what do we know about modulators and mental health? There have been, starting in 2017, we started to see reports emerging of a variety of kinds of mental health side effects: depression, anxiety, memory, brain fog, trouble with word finding, trouble with sleep, suicidality in some cases. And so the Prioritizing Research in Mental Health, or PRIME working group, did a comprehensive search of the literature to figure out kind of where are we with this, where are the gaps, what do we still need to know, and identified, again, key gaps and study design considerations in a variety of areas. And we found that there are some limited studies that identified behavioral changes with modulator exposure in rodent models of depression, anxiety, and cognition. Actually, Leah Reznikov, if anyone saw it yesterday, presented really great unpublished data looking at her mouse studies where she added an inflammatory mediator, IL-1 beta, to the lungs of mice, and then looked at the influence on behavior of those mice and saw increase in anxiety-like behaviors, depression-like behaviors, but actually much more so in female mice than male mice. So this is kind of this sex-specific link between inflammation, lung inflammation, and behavior that, again, is analogous to mental health in people. And when we look at human studies that, some of the European groups were able to get kind of pre-post measures, they were able to see improvement in depression and anxiety in many cases, or no change. But again, we have these case reports that show subgroups have new or worsening symptoms. And if we kind of think about that, it makes sense that if you try to average things out, you're going to miss the people who might worsen, right? Because we do expect some improvement when people feel better. All right, so I'm going to quickly take us through a few resources. I just want to let you know we have resources for people with CF and for teams on psychosocial considerations of Trikafta. There are a variety of, I really spent more time on depression and anxiety. We have other mental health conditions that have potential impact on CF care and outcomes, including medical traumatic stress, ADHD and neurocognitive conditions, substance misuse. I'm going to kind of put this together briefly with the case and then just tell you about a few other resources and then wrap up. So this is a case of an adult with CF who has depression that tends to get worse with CF exacerbations. When she gets sick, there's more inflammation there. She doesn't have the energy to work. She gets more financially stressed because she's missing shifts at work. Then she's feeling more isolated because she really loves her work. then she becomes more depressed, and then she's doing less and less, and then she's not getting her airway clearance, right, and her pulmonary symptoms are worsening. And then she says, when I feel depressed, I feel hopeless. Like, it doesn't matter what I do, my CF's going to keep getting worse. So then she doesn't feel motivated to reach out to the CF team or pick up her medications at the pharmacy. Then the exacerbation's getting worse and worse and worse, right? She's waiting kind of until that last minute to call the team. And at the same time, as things get worse, she starts to have more and more hemoptysis. And then she's getting panic associated with the hemoptysis. And she's really got this medical traumatic stress reaction associated with the hemoptysis. And that makes her want to avoid physical activity and avoid taking care of herself. And then her depression gets worse and worse and worse. Okay, so how can we break that cycle? In her case, it's medication and psychotherapy. So if we can intervene anywhere in this circle, we can start to improve things, right? So in this case, by having her become more aware of her emotions, cognitions, and behaviors that contribute to maintaining this cycle, reframing her maladaptive thoughts. So yes, my CF's getting worse, but if I reach out to the CF team now, I might actually stop this exacerbation before it gets worse. And problem solving, how can I find work that's less physically demanding so I can maybe continue it more when I'm sick? How do I stay in touch with my friends even when I'm not well? She starts to do more exercise, particularly yoga. She becomes more consistent with sustaining daily care, but she still tends to have this depression and anxiety relapse when her exacerbations kick in. And then she starts Trikafta, right? So she sees more energy, more stamina, her cough's better, her quality of life's better, her functioning's better. She can be working, she can exercise, she's doing more social activity. So her mood has been really good, less hemoptysis, so there's no panic, there's less avoidance. And then she has an insurance problem, and she can't get her Trikafta, right? And you see that those pulmonary symptoms come back and those mood and anxiety symptoms come right back. And then when she gets Trikafta back, she's kind of back in this better place. So again, this, again shows how all of these things can really come together, but you can intervene anywhere there. And again, I just want to let people know that we have resources for medical traumatic stress and procedural anxiety on cff.org and at the resource library, resources for ADHD, resources for substance use in CF. I want to remind people about the Indiana University online education program. We have a great course with free CME about mental health in CF care and also palliative care in CF. We now have an online CF-CBT training. So anyone of any discipline who would like to be trained in CF-CBT, this is a free training. It takes about 5 hours. You can do it at your own pace. And once you complete training, if you want to, you can join our CF-CBT implementation study. We'd love to have you join so that we can understand the reach of this intervention. And you can also receive consultation support if you want to, optionally, to deliver CF-CBT at your practice. So scan the code or reach out to me if you're interested. And then finally, I wanted to mention that retrial, which is a study of people with CF ages 6 or above who had mental health or liver side effects on Trikafta, where they had to reduce the dose or discontinue, and they're now starting a lift trek. They can participate virtually in this study. We're taking national referrals, and you can find a retrial site to refer to. You just need a mental health coordinator who's going to receive alerts to provide some study records, medical records, and your center can be reimbursed using a CRISP form. Thank you very much.
Does anybody have any questions regarding this presentation? I have one. So would you recommend that a pharmacist or a mental health provider periodically check in with any patient that initiates modulator therapy? So
Yeah.
I just feel like sometimes we don't find out until maybe a little further down the road that they're struggling with these issues. And so that vicious cycle has started. Whereas if there was a periodic check-in on some interval after initiation, maybe that could be caught a little sooner.
Absolutely. So the CF Foundation, ECFS mental health guidelines have not been updated, for the era of Trikafta and Kaftrio, which is the European version. However, the European standards of care have been updated and specifically do recommend that for anyone initiating variant-specific therapy, such as modulators, that mental health be assessed no later than 3 months after starting, and that's probably too late. But for sure, we don't want to wait a year to screen them again and realize things are going off the rails. It's probably about 10% of people who have some worsening. And again, most people may improve, and happy to talk about, what those mechanisms are, and have a talk later today where I'll be talking about that more at 2:30. But for sure, we should be checking in with people, just like we are about, checking your liver once a month, right? And are you having acne, and are you having weight gain, and how is this going in general?
Somebody asked to bring up the Indiana slide again.
Oh, sure.
And then I had a question on the slide with the bidirectional link between depression and inflammation. Are there any studies, like as far as like how long that takes for those numbers to go down? Does that make sense what I'm saying?
If you intervene with inflammation, you mean, like
Yeah,
with exercise, or
yeah, like how like someone's depressed, we're going to do a study, measure these levels,
Yep.
Do a project or anything, and then what's the after effect on that?
Yeah, I mean, these all of the studies I showed were meta-analyses, but they're not super long studies. It's not like they're 10-year studies of exercise, right? So if you do 12 weeks or something like that,
Then
you expect to see to start to see some differences as you make those changes. Yeah.
And then we have another question. What is the easiest way for the respiratory therapist, physical therapist to start with these resources?
Which resources are you thinking about?
Since it's my question, I'll hop up and ask. You've provided us with a whole bunch of awesome resources,
Yep.
and I have to admit, it's a little overwhelming for the person who doesn't completely know what to do to try to help patients. I was fortunate to join the pre-course about medical trauma, and it's very inspiring, and I identify with it. Where do I start with all of those cool resources that you just zipped on the screen?
Right. So you can do it a couple of different ways, right? One is to say, what do I see in front of me? And oh yeah, there was that substance abuse thing. Let me go find that tips for teams, right? Or you can kind of pick a thing, right? You can say at our center, we want to do a better job of looking for medical traumatic stress. And this is, I brought back up this Adi Cuneo, who presented at our session. This is this model of universal, targeted, and treatment. So you see kind of that pyramid. So there are some things we can do for everybody, whether we know that they've had medical traumatic stress or not. There are actually very high rates of medical traumatic stress in people with CF. So again, we're going to kind of assume they do rather than assume they don't. We can do education with the care team. We can do patient and family education. One of the things that was really remarkable at the our mental health advisory committee meeting this year, where we were talking specifically about how can we move things forward with medical traumatic stress. We have a really fabulous parent on of like a 12-year-old on our committee, and she said, until last year I had never heard of this, this idea of kind of procedural anxiety, medical traumatic stress, and like where that might lead over time. So if we just make people more aware of it, then parents and patients can start to advocate for themselves, right? Like, maybe I don't want you to try again on that stick. I'd like to have someone else do it, or I'd like to come back and do this at another time, or hydrate better, right? Or giving that kid some sense of control over Do you want to have your shot at the beginning of the visit and get it over with, or do you want to have it at the end, right? So just having some sense of control and even maybe making a plan as we get into this more targeted intervention for people with mild symptoms, right? Okay, what helps me? How am I going to approach this? Am I going to bring some music with me? Am I going to bring an iPad and watch, a cartoon I like? Am I going to, listen to music, right? So how can we use distraction, or how can we use having a favorite person there, or not too many people in the room? There are all kinds of different approaches, evidence-based approaches that we can take. And so, is this something you want to do as QI, right? Do you want to start screening for medical traumatic stress? But I think just becoming more aware and taking things step by step, I think is really important, because that can impact the language that you use with folks as well, right? Is this someone who's being difficult, or is this someone who, what have they been through, right? And what kind of trauma have they experienced, and how is it that this is such a tough thing for them?
Wait, this is our last question for this session.
Hi, can you hear me again? I'm Lucy from the Manchester in the UK. I was just wondering, have you had any early experience of alpha trek in the real world and its impact on mental health in a positive or negative way?
I think it's too soon to tell. I will say that there's, some positive chatter on listservs, and I've heard some anecdotally positive things. We're not doing interim analyses for our retrial study, but I'm certainly interested in hearing what people's experiences are. I will say that here in the U.S., there's been a slower rollout of ALIFTREK than with Trikafta, Kaftrio, right? At that point, it was like, okay, people really need this more effective modulator. We want it yesterday. And now, for us, a lot of people are saying, there were definitely some early adopters, but other folks who are saying, let me see how this goes. Let me see what I'm hearing from other people with CF, or maybe, do I want to rock the boat or not? And so I think as more data emerges about, both, kind of there are differences in sweat chloride, right, with ALIFTREK over Trikafta, Kaftrio. What are the differences in quality of life like? And again, is there a chance that I might have fewer mental health side effects? Is that worth trying? It will be definitely interesting to see. So again, if you are in the US and you have anybody who's in that boat, right, who has that reduced dose, or they've discontinued either for liver reasons or mental health reasons, they can do survey-based study and help contribute to our having some information to provide to people who are kind of waiting to see about what are the chances, if I make this change, am I going to have the same thing happen again? That's really our clinical question here. What are the rates of discontinuation or reduced dose going to be?
Thank you very much.
Thank you so much.
All right. Our next speaker is Cadence Kuklinski, who is now Dr. K. I got a thumbs up. I said it right. She's an associate professor of pediatrics at Washington University in St. Louis and the associate director of the pediatric lung transplant program at St. Louis Children's Hospital. Prior to attending medical school, Dr. K obtained a degree in nutrition and dietetics from St. Louis University, completed her dietetic internship at Barnes Jewish Hospital, and became the lung transplant dietitian at SLCH. After 4 years in that role, she left St. Louis to attend medical school at Des Moines University in Des Moines, Iowa. She returned to St. Louis for a pediatric residency at Cardinal Glennon Children's Hospital, and then completed her pulmonary fellowship at Washington University, where she remains there as faculty. She specializes in lung transplant, aerodigestive medicine, and fellow education. Please welcome Dr. K.
Hi, everybody. Thank you very much for that introduction, and thank you for having me today. Okay, my disclaimers, I have none. Okay. And I am including some photos of a patient in my presentation, and his family provided written permission to include his photos. Why is this keep, what am I doing wrong? It's going backwards. Just do that. Okay. So I'm going to talk a little bit about what it's like to transition both into the transplant space and then beyond. We're going to start with, so your patient needs a transplant, right? So we're going to talk about things that happen at the time of referral, how the teams share information, how we create bonds, what happens during the transplant process, including things like how often is a patient seen, and then after the transplant. So what is the respiratory regimen like post-transplant? Who follows the patient long-term? And how does the home team kind of let go and share in the care of this patient that they've been taking care of potentially for their entire life? Okay, so when to refer. So we know that early referral is key, right? So getting a patient to a transplant center early is important, both so that we can help to prevent some of the comorbidities that happen with transplant with much sicker patients. And also in order to, sort of along the lines of our last talk, give patients and families more time to sort of acclimate to the transplant process, get used to thinking about themselves as a possible transplant patient, and all of the mental health challenges that can come with that. I do feel like there wasn't a great place to fit this into this talk, but I just want to mention, the impact of triple therapy on our referrals. Particularly in pediatric transplant, the number of CF patients who we've had referred for transplant since the initiation of Trikafta and Alyftrek has plummeted. I've never been so happy to be almost put out of a job, to be quite honest. But it's a much smaller number of patients. And also that means that the patients who we are seeing are the ones who have had more challenges and are typically not modulator eligible. And so that just creates a different kind of patient population who we're being referred. They're often sicker. They have more mental health challenges, things like that. So at the time of referral, this usually starts by the home center reaching out to the transplant team. It typically starts with provider to provider contact. I am on call this week while I'm here. I've gotten multiple emails from different places, people saying, hey, I've got this patient, can I talk to you? We have a standard set of records that we request that both include a letter from the referring physician that sort of tells us all about the patient's care and why they're being referred. We typically prefer to have some imaging, some labs, things like that. A social work evaluation is also one of the things we require for that early part of the referral, so that we can get information about what is the support network like for this family and this patient, things like that. And then once we have all the information and we kind of look through it and say, okay, there are no immediate red flags. There's nothing in here that's a hard stop that says this patient can't proceed to a transplant evaluation. We reach out to the family and we provide education. Typically that's done by our coordinators. It's about an hour-long-ish phone call where they kind of run through the sort of what we call quick and dirty, like here's what transplant is like and what life with transplant is like. And allows the family to ask some questions. And then that's when we say, so now that you've heard what we have to say, are you interested in pursuing evaluation? Some people immediately say yes, some people say no immediately, and some people want to think about it a little bit. So if they do decide to proceed, we have them come for an in-person evaluation. Our evaluations are inpatient and outpatient, sort of depending on the patient's needs. I'm going to talk a little bit more on that in a future slide. And then at our center, patients relocate. So I think that it's important to know that not every transplant center, pediatric or adult, necessarily requires relocation. It is something that historically our center has done, I think possibly more than any other center in the country. And we have some reasons for that. So whenever a patient is ready to be actively listed, we ask that if they live farther than 2 hours away from St. Louis, that they move to within that area. And once they do that, that's when we actively list them, and then we start with regular clinic visits with a provider and a coordinator. It sort of depends on the patient's needs, how often that happens. Sicker patients will be seen every single week. Patients who are a little bit more stable come like every other week or so to see us in clinic. They also get regular physical therapy visits. That's anywhere from 1 to 3 times a week. And the physical therapy that they are receiving while they're waiting is structured more of as a pulmonary rehab program. We know that having patients in the best physical shape possible is really key in reducing their post-transplant morbidity and mortality. So we take the physical therapy pretty seriously. They also see our social worker, our dietitian, and our psychiatry and psychology teams as needed, just to kind of help support them through this phase. And then they're getting monthly labs. We do, since the pandemic and just everything happens more virtually and more remotely, we have had a few patients that who have lived outside of that 2-hour time frame and then relocate when we get an active offer that we've accepted. There are pros and cons to that. You have to set up some sort of plan for a flight, typically in advance. The degree to which that's covered by insurance is highly variable and is getting increasingly more challenging. And of course, you're limited a little bit by like how far away they are and how quickly they can fly there, because we need them there for many hours before they're actually going to go to the OR. And also, if a patient is at all self-pay, and you do a dry run, so that means like we accept an organ, we call them, we make them fly down to us from Chicago or whatever, and then something goes wrong and we can't transplant them, then all of that money that they spent on that flight, which it's a medical flight, so it can be $10,000 to $20,000, is just gone. So there are definitely things that are challenging about having to uproot a patient and a family and bring them to St. Louis, but there are challenges about letting them wait at home too, and that's something that we sort of work out with each family individually. And so then your patient gets the call, and we say, we've got a set of organs that we've accepted for you. They come into the hospital. They are quite often, as this patient was, surrounded by family who are very, very excited. And we do all of their pre-op work, and then they go to the OR. So after the transplant is completed, we have a couple of goals, and you'll notice most of these say as soon as possible. So we like to be pretty aggressive as we get started. We want to extubate our patients as soon as possible, as often as we can, depending on a patient's anatomy and medical needs and things like that. We are increasingly using epidurals for pain control. Higher epidural, not the same kind of one that you would get when you're having a baby and you can't get up and move around, but one that's up higher that really helps provide a lot of relief for that chest pain, and they can get out of bed and move around much quicker, and they're not as heavily sedated on other like IV pain meds. We want them off that ventilator, and maybe a lot of people are extubated to BiPAP or high flow, but impressively, most people get off of that kind of support pretty quickly too. And we want them breathing on their own and coughing and doing all those things as soon as possible. It's also important that we start enteral nutrition as soon as possible. We want, these, particularly we're talking about CF patients, right? So we want to make sure that their gut is moving, that we're getting things moving. The narcotics can slow things down, cause more constipation. And so getting food in there, getting things moving is important. It also affects our drug levels and some of the immunosuppressive drugs that we're monitoring. So trying to get us as close as possible, as soon as possible, to like what that is going to look like for them going forward is important. They start physical therapy also as soon as possible, basically as soon as they're awake. We're starting to move them and ideally have them up and walking around within a couple of days after transplant. And then airway clearance is sort of variable. Most people are not going to need airway clearance for a big chunk of the time after transplant. Sometimes you're a little uncomfortable or a lot uncomfortable after the surgery. It's hard to cough. It feels different when you cough after your lungs have been transplanted. And so some patients may need some help getting some of that mucus and stuff up just from kind of laying there for so many hours. As you might imagine, vests are not typically terribly well tolerated in this time frame. You've got a whole bunch of staples and chest tubes and things like that. So we're doing manual CPT. We're using percussors and exercise for our airway clearance at this stage. And then discharge post-op. So patients are typically in the hospital for about 2 weeks. We've had some patients really sail and get out faster than that. And then some patients have some complications and they end up being in the hospital immediately after their transplant for more like 3 to 4 weeks. But 2 weeks is pretty average. You can see Will here is working on his blue card. So every patient gets a card that has all of their medications written on it, and it's written on it in pencil, and they update it at various visits whenever we change doses and things. He's really good about keeping his card up to date and memorizing it. It's really great. So after they go home, they come to clinic visits with us weekly. And when I say home, I mean locally. We do ask that patients stay in St. Louis for up to 3 months after their transplant, and then they can go home. But so they're staying locally. They come in every week and see us in clinic. And that's, again, provider and coordinator. They do PFTs with all of their visits. Interestingly, patients and families are often pretty disappointed by those first couple of PFTs. They're not hitting those hundreds and high 90s like they were all hoping. It takes a while, right, to get that strength back up, to get all that junk out of your lungs, and to really get up to that optimal function. So sometimes patients are like, well, these don't really look much better. I'm like, but you feel so much better. It's going to get there. We're getting there. They get labs twice a week, where mostly that's for drug level monitoring. And once we hit sort of a steady state, we sort of space off on that. They're still getting pretty regular physical therapy. So still 1 to 3 times a week, depending on how well they're doing, really focusing on that pulmonary rehab. Again, all of this starts spacing out after that 2-month mark, and then we release them to go back home, wherever that is, after month 3. Some transitions, okay. So after transplant, so what happens after that 3-month mark? So they continue to return for regular evaluations, which are scheduled at specific intervals. I have the list of them here. So we see patients 1 week, 1 month, 2 months, 3 months, 6 months, 9 months, 1 year, and 1.5 years. And then they come back and see us in St. Louis every 6 months for life. All of these evaluations are structured around clinic visits, and these evaluations typically take a couple of days. So they're back in St. Louis for a couple of days with us each time they come. They get clinic visits with the transplant provider and any other subspecialists that they are seeing with our group. They'll get their regular labs. We get a variety of imaging. It depends on which evaluation you're at that you get, but it's a lot of CTs, perfusion scans, things like that. And then they get transbronchial biopsies. So we do transbronchial biopsies at all of these evaluations up into that 1.5 year mark. And then we stop surveillance bronchoscopy. Surveillance bronchoscopy itself is not without risk. There can be significant bleeding associated with the biopsies. You're at risk for pneumothoraces, things like that, and hospitalization after the procedure. Also, we're screening for acute rejection with those biopsies, right? And so that also comes with a high degree of risk, and it is not always symptomatic. And so we feel like the balance is there for screening for that until about that 1.5 year mark. Beyond 1.5 years, you only get bronchial biopsied if you're having symptoms. And then partnering with the home team, right? So every transplant patient needs a primary pulmonologist and team. So the transplant team just really, particularly if we aren't in the same city, cannot be the only team taking care of this patient. They need people who know them, know their medical care, and are engaged in that care in their home city as well. They often are also still needing other subspecialty care, right? Because the rest of their body still has CF. So a lot of people still need a GI doctor. They might need an endocrinologist. That post-transplant patients often have to see renal specialists because the drugs are pretty hard on your kidneys. And it can be really challenging to get that care covered long-term at the transplant center. And so it's really important to still have engagement with the team at home to help provide that continuity and good communication back and forth between both the teams so that wherever the patient is for a particular visit, they're getting good care. And then I've just got a couple of slides on the stuff that's less fun and a little bit harder to talk about. So what happens when a patient is decompensating? And again, this is where I think good continuity and a good relationship between the transplant program and the home team is really important. Because most of the time somebody gets sick and they're not in St. Louis with me, right? They're home with y'all. So I need your help to figure out what we're doing next. So even patients with mild sick symptoms, we take those very seriously. These patients are immunocompromised. They are at risk for sequela from pretty mild diseases. So everyone who has a cold gets a viral swab. If a transplant patient has RSV, COVID, or flu, we are treating that with antiviral medications. Whether or not they have to be admitted for that treatment depends on the severity of illness and the availability of drug in your area. But we have to know if they have one of those because we have to treat it. We ask that they do PFTs. And again, coming all the way to St. Louis for just a viral swab and some PFTs is a big ask. So doing that at home is really important. We also have something at our center that we call actually our acute decompensation protocol. It's a written protocol that we very routinely are sharing with our ER, our ICU, and then our pulmonologists are helping to guide our other teams to help take care of these patients. But we also share that with our referring centers. We email it, we send it, we fax it to all sorts of other places. If a patient presents with more serious illness, what are the things that we need to do more immediately while we're trying to get that patient stable and deciding whether or not they're going to come to St. Louis and see us. So it's guidelines for admission, what sorts of evaluations need to be done, and then the possibility of transfer to the transplant center. And then, of course, the thing that no one likes to think about, but chronic rejection, right? So you have probably heard that chronic rejection is pretty common post-lung transplant. So sadly, in the last 20 to 30 years, we really haven't changed the rates of chronic rejection much, despite all sorts of advances in medical care. The statistic that is often quoted is that the 5-year survival rate after transplant is only 50%. That can be broken down in a variety of different ways and is slightly different for different disease groups, age groups, things like that. But when you look at worldwide data, that's still about where we are. And so it is likely to happen at some point to most patients. Diagnosing chronic rejection typically is going to require treatment at a transplant center. So most of these patients are getting transbronchial biopsies. We've really gotten away from doing open lung biopsies because of the increased morbidity and mortality with those and the fact that they're not really any more likely to pick up some of the things that we're looking for to diagnose rejection. Not every center is going to be in a position to do a transbronchial biopsy, so the patients usually come to us if we have concerns about that. What the treatment course will look like depends on the type of rejection. A lot of patients actually do end up needing increased airway clearance, and so they may end back up on a vest using an acapella, something like that, to help clear mucus from their lungs, particularly if they're developing some bronchiectasis with this process. And sometimes we are able to transfer care to a local center once we sort of diagnose what kind of rejection we have and what the treatment plan is going to be. And then if we reach a point where we're pursuing end-of-life care, where that happens can depend on patient preference too. Some patients feel more comfortable staying in the hospital at the transplant center and just being with us, and other people want to go home. And that can be either home to their home hospital or home to their actual home, making it easier for family to visit and things like that. And that's where, again, those relationships and having maintained those over the course of the patient's life can be really important because we make sure that they are feeling supported and cared for and that they're still getting all of the appropriate care, even if they're not in St. Louis with us. So one of the questions that I was asked about like giving this talk was like, could I talk about like how should the home team let go? And I hope that I've done a good job of convincing you that you actually shouldn't. I want to work with you and not take your patient from you. And so I hope that this sort of inspires you to help stay in contact with the team. And I think that that contact is important from all the members of the team. Like, I want to hear from the RT who sees this patient regularly about what kind of airway clearance they like and don't like and why not. I want to hear from the physical therapist about like how they're able to motivate this kid so that we can continue to do that after transplant too. So, those are my references. Thank you.
So we have a few really good questions. The first, do you begin to take on a greater role again for respiratory care once the patient approaches end of life post-transplant?
So I don't.
Somebody in the room that asked that
somebody ask that
question
one?
could give a little more clarity to that question.
Sorry, made you get up.
Hi, I don't guess.
Yeah.
Hi, sorry, I'm just. I guess it may be different in the UK. We have our transplant centres within our trust, which we're really lucky about. But it's then that balance of which team takes on that role from a respiratory care point of view once the patient starts to reject. So we tend to take that patient back from the transplant team. But I was just wondering if that was different in other areas.
Gotcha. I think it depends a little bit on exactly what's going on with the patient and how comfortable the team at home is caring for a patient who's chronically rejecting. Because there are so many centers in the US, there are often a lot of centers who just don't have a lot of experience with a really sick patient who's in chronic rejection. And so that comfort level might not be there. And in that case, then the transplant team sort of maintains ownership. But I sort of feel like our job is to kind of fit that with what the family and the patient might want. So if a patient wants to stay with us, we're just happy to do that until end of life. But if a patient really wants to go home, we try to do as much talking and support with that home center as we possibly can to help make sure that like all of the things can get done at home and that everyone, the team and the patient and family feel comfortable continuing to receive care wherever seems best to them at that time.
The questions keep coming in, so that's fantastic. And the reason that I had asked about how you keep the team in the know, their home team, we've had situations, thankfully not many, because we've not had to refer many for lung transplant with highly effective modulator therapy, but we had siblings that came to us and they went to a transplant center and we never saw him again. And there was no communication, and that is a lot of, I think, stress and mental anguish on the team because we provided care for him for 16 years, and then all of a sudden we never saw him again.
Yeah.
And there was really no communication with us from the transplant team. So, so thank you for addressing that. I wish it was more like that where we are, but it's not. But then another question that we had, are post-transplant patients on HEMT?
That I'm going to say like also just kind of depends on each patient's specific needs. So not all, but some of them are.
And is there an interaction or adverse reactions between modulators and transplant medications?
Not typically. I mean, we're monitoring drug levels pretty regularly. And so we don't tend to see a big change or jump in, like, for example, TACRA levels or things like that. But it's something that we're monitoring pretty closely.
What are your guidelines for not doing transplant? Like if a patient has cepacia or anything like that, is there a guideline?
Yeah. So Burkholderia cepacia, sinus cepacia is still a hard stop. So that is one of the few, actually. There aren't a ton of 100% red flags.
Right.
Each center has some slightly different things. That would be one that would be pretty consistent across centers. I will say that the patient that I featured had a multi-drug resistant organism that we were able to come up with a pretty complicated both pre and post transplant antibiotic regimen for. And while he did ultimately develop chronic rejection and passed away, it had nothing, he never grew that organism again, and it had nothing to do with that. So I think if you've got a good relationship with your ID team, not all multi-drug resistant organisms can be contraindications, but you have to have a plan for treating that. There are some other team specific things. The appetite for transplanting a patient who was like already on ECMO or something can vary center to center, and honestly like month to month. So if you aren't sure, just check with your home team, because it sort of depends on everyone's appetite for risk at the given time.
All right, we have time. There's a ton of questions. And what we can do is provide these questions and get answers for you. There's a question about chronic poor adherence to the CF management and how that can be part of the reason why their lung disease is so advanced. How have you handled families who are not following pre-lung transplant protocols, and do you have a threshold to deactivate them from the list?
Oh, that's a great question. You got to remember I'm a pediatrician, right? So we're like really nice. And so like we tend to cut people a lot of slack. And so I can say, trying to think, I have only had to temporarily deactivate one patient. It was not actually a CF patient, and it was for mental health concerns, which we aggressively addressed both with our home psychiatric team and with our team locally, and got on top of. And that patient has continued to need pretty aggressive psychiatric care, even post-transplant, but we've made that work. So I think the question was about like non-adherence and like how we deal with that. So that does happen a lot, right? Like a lot of patients who we get referred are not necessarily like the poster children for adherence to the therapies that have been prescribed. I think just like a non-transplant center does, right? You sort of explore like, why has that happened? Why are there challenges? What of those are modifiable? What can we do to help families get better about doing their things? It's really important, we are very clear when patients come to see us that transplant is not a cure. It is trading one disease for another. And so you are not necessarily like everything's going to be so much easier and less high maintenance once you get a transplant. Their adherence to the medications, if anything, is even more important. Missing your tacro for a couple of days truly can be the difference between life and death. And so it's not something that you can be flexible on. And so sometimes we have a contract that we have put in place with families who have struggled, and how long we make them adhere to that contract and like demonstrate more appropriate adherence depends quite honestly on how sick they are and how much time we think we have to wait. But 6 months is usually a pretty good time frame where we're like, okay, can you do this for 6 months and see us regularly and help us sort of figure out why there are problems? Yeah.
One last really quick question. What is the 5-year survival statistic? And do patients get the opportunity for a second transplant?
Yeah. So that 5-year survival statistic, it just means that we say the 5-year survival rate is 50%, which means that 5 years after a transplant, on average, half of patients have died. The curve is, I didn't include there's a bunch of slides that you can get that like show the curve for that. So it's actually pretty high. The death rate is higher in the first 1 to 2 years. If a patient makes it 2 years, that death rate drops off pretty significantly. And so if you make it 2 years, you're more likely to make it 10 years after your transplant. And unfortunately, all of the things that we've done as far as immunomodulator therapy and things like that really haven't changed that much. And it is one of the worst of any of the transplant organ systems. When you think about it, the lungs are one of the only organs in your body that are continuously exposed to the outside world, right? So we're just constantly insulting our lungs with viruses and other things. And so it's just really hard to protect them as well as you can a heart or a kidney. That's a lot harder to get at for germs and things out there.
Okay. Thank you so much. All right, I have the pleasure of introducing Dr. Marissa Kilberg, who is a board-certified pediatrician, currently an attending physician in the Division of Endocrinology and Diabetes at Children's Hospital of Philadelphia. She completed a master's degree in medical education at the University of Pennsylvania and conducted research on the occurrence of hypoglycemia and cystic fibrosis with support from the CF Foundation. She continues working in CF with support from Envision program with key interests in puberty, growth, body composition, in addition to CF-related diabetes. So please welcome Dr. Kilberg.
Thank you very much, Dawn and Kim, for having me here today, and to all of you for your attention. I'm going to switch gears a little bit and talk about one of those insults to the lungs, and certainly diabetes can affect our lung health. My only disclosure is really the support from the CF Foundation that I'm very grateful for. And I am hoping to go through throughout this session, just differentiating the types of diabetes, really CFRD being the most important, recognizing the impact of CFRD on our respiratory status, physical function, and nutritional status. Understanding just the basic principles of insulin management and pump therapy in CF. Really, specifically the exercise considerations, hypoglycemia risk, and glucose monitoring. So what is CFRD? It has the characteristics of both type 1 and type 2 diabetes. There's insulin deficiency, need for insulin treatment, so something like you might see with a type 1 diabetes. There's insulin resistance and really that slow, insidious, progressive onset, similar to what we see in type 2, but it is very unique. There's early on in CFRD, we see this delayed first phase insulin secretion. So at the very beginning, in all of our patients really at young ages, just not being able to quickly get the insulin out, although eventually getting it there. Somewhat related to this, we see more frequent low blood sugars, so kind of overcompensating a little bit and having hypoglycemia. Of course, with CF, we think a lot more about undernutrition. The landscape has changed dramatically, and I'll talk about that as well. And then the impact of everything else going on in the lung health, the body health, infection, inflammation, whether or not steroids are used, certainly impacting. So I think we all know this. CFRD is very common. So when we look at this registry data, you can see in this red line the percentage of individuals with impaired glucose tolerance, and you can see that between this 10 to 15 years of age, that around 15% of people are going to have impaired glucose tolerance. Once we get to 20 years of age, about 20% of people will have CFRD, and then around 40 years of age, 40% of people with CFRD. So just wanted to go back and kind of compare and contrast a little bit between the types of diabetes. Looking at prevalence, type 1 diabetes in the general population, somewhere around 0.4%, type 2 around 11% in North America. CFRD, we're of course looking at the prevalence amongst patients with CF, is around 25%. So it's quite common in terms of that prevalence. I mentioned the insidious onset. Insulin deficiency is severe but not complete, and so seeing things like ketone development is more rare. We do see the microvascular complications in CF, and at least as of the most up-to-date data today, macrovascular complications and metabolic syndrome are less common, but I think an evolving landscape. Our organizers asked me to comment a little bit on like type 1 and type 2 diabetes in CF, and really the prevalence of islet autoantibodies in a publication from this year in JCF is not exceedingly common. It's the prevalence of autoantibodies is between 1 and 8.5%, which is not very different from what we see in type 2 diabetes. Just having autoantibodies does not mean that you have type 1. And so it's really similar in comparison to what we see with type 2. That being said, I certainly have many patients that do have type 1 diabetes and CF, or a few patients. Insulin resistance, of course, will increase with overweight and obesity and CF. But really the recommendation from this recent review is that all diabetes in this population should really be classified as CFRD unless there's clear evidence of autoimmune destruction. And so when we think back to that chart, we don't expect complete insulin deficiency, and we expect a more slowly progressive onset. And so if you're seeing a really acute onset of diabetes, if you're seeing ketone development, those might prompt you to investigate a little bit further. This is just additional registry data. There's not the full 2024 data released yet or publicly available, but in the highlight snapshot, they comment that, again, 25% of individuals with CF will have diabetes, and 1% of those are recorded in the registry as having type 1 or type 2. So predominantly what we're seeing is what we call CFRD. I won't go into too much detail about the mechanisms, but just there's lots of reasons why CFRD develops. So there's issues with the exocrine pancreas itself. There's the impact on the islets, maybe intrinsic islet abnormalities, issues with our gut hormone signaling. We'll talk a little bit more about incretins in just a few. Genetic susceptibility. So outside of just CFRD, cystic fibrosis itself, gene severity or mutation severity, and then type 2 diabetes associated genes. Those all contribute to insulin insufficiency. And then I mentioned before that component of insulin resistance. So lots of infection, inflammation, if there's been corticosteroid use, overweight and obesity, and aging itself. So all of those can lead us in that direction. When we think about the glucose abnormalities in cystic fibrosis, we think about this on a continuum of increasing risk. And so this goes from indeterminate glucose tolerance, impaired glucose tolerance. We can see diabetes and CF without having fasting hyperglycemia, so that can be a later finding. All of these on this continuum are thought to be increasing risk of ultimately developing cystic fibrosis-related diabetes, although in terms of the glucose tolerance tests themselves, we do see a bit of bouncing back and forth. But the overall ultimate risk of developing is higher once you've kind of hit that indeterminate to impaired state. I think what you probably really care about is why this is important, why we're talking about diabetes, what that insult is. And so having insulin deficiency, having higher blood sugars means glucose in the airways. And having glucose in the airways, bacteria love glucose, so increases risk of infection. And you can see kind of the overall lung function impact in various ways. So I really like this study that shows based off of center screening rates. And so in green, you have the centers that screen the best, that are screening 80 to 100% of individuals with glucose tolerance tests annually. And it won't surprise you that those who are screening 80 to 100% of individuals versus those who are screening 20 to 39% of individuals are detecting more CFRD. But really impressively is what that means in terms of lung function. And so at diagnosis, those who are screening a much higher proportion of patients have, 15, an increase in FEV1 or a higher FEV1 by about 15%. And that's pretty impressive. And I think also impressive is looking at, the decline that happens before diagnosis because we're picking up late, and then also the lack of kind of meeting in the middle after diagnosis. So it's really a loss of FEV1 if we're not picking up CFRD early. And I think that really highlights the impact. When we think about other relevant outcomes, certainly accelerated decline in lung function, more frequent and slower recovery from pulmonary exacerbations, higher infection burden, increase in inflammation, poor weight maintenance. Again, there's a changing landscape, and we'll talk about that, but that has been really a hallmark of our CFRD therapy. At this point is really, seeing that lower BMI before detection of CFRD, and then, really wanting to help that aspect. And there's increased mortality risk that really parallels what you see with some of these severe pathogens that we discussed. So it's certainly relevant. I like this study as well in terms of thinking about what our actual control of CFRD is and how that impacts our patients following exacerbations. And so this study was out of Pittsburgh looking at individuals who, after hospitalization, go home on IV antibiotics. And what you can see is that those who had good CFRD control in the hospital had much swifter recovery of FEV1 and sustained recovery of FEV1 in comparison to those with CFRD with poor control who started off at lower pulmonary function, really didn't gain back as much, and really don't sustain as well. So in terms of treatment, today, insulin is the only recommended therapy. It's the only thing that has been shown to be associated with improved nutrition, with improved pulmonary function and survival. But I certainly think that the landscape is changing and recommendations are likely to change over time with the data that we're gathering. And we'll talk a little bit more about ongoing investigations in GLP-1 use as well as nutritional modification. In terms of treatment control, we know that hyperglycemia is catabolic and giving insulin is anabolic. So we really hope to improve morbidity and mortality by reversing some of those catabolic effects. We also want to prevent the long-term complications. I mentioned before, but microvascular is really what we see in CF today, and that's probably also compounded with other microvascular insults that our patients with CF have. But, macrovascular may occur over time as patients are living longer and just having different phenotypes overall. There's many challenges to managing CFRD. It's a new problem. There's variability in insulin productions and changes in insulin needs. Commented on that a little bit, how CFRD is different than other forms of diabetes. And there's the low blood sugar aspect of things. There's also lots of CF-specific considerations in terms of the caloric needs. We talk a lot about the CF legacy diet, the really high-fat diets, the interpretation that some patients have had over time in terms of the glycemic load, so really trying to get any calorie is a good calorie, that sort of thing, that can be hard to dispel and hard to, especially in our pediatric population, hard to really change those desires. Intercurrent illness and glucose fluctuations, corticosteroid use, and really the burden of care. Having yet another thing to do, I think can't be taken lightly. Our patients do a lot. You all do a lot with our patients in terms of their respiratory supports, their physical supports, and really adding in something else is a lot. With that being said, there was a study out of our center, a qualitative study looking at some of the facilitators to CF care, and so I'll share just two quotes from this. They told me that you really need to start taking an aggressive stance on this. As soon as they told me it could affect lung function, that's when I really started listening. Yeah, this needs to change. And then I have more to do, like more treatments, nebulizers, and enzymes. I have to worry about all of that. All I have to do with my diabetes is give myself insulin and check my sugar, and that's all. I wouldn't say that that's a common thing that I hear when I'm talking with patients, but sometimes you're surprised. Sometimes people really take this addition to their regimen as not being as significant as what they're otherwise doing, day in and day out. But I think it's really important to not walk into an encounter with that mentality or that expectation that our patients are going to take it that way, because I do see a lot of impact to the change and the addition of another therapy. And so I really feel out the room and really work closely with the patients and kind of customize how quickly I'm jumping into things based off of what I'm getting back from them. So for you all, I thought highlighting some exercise considerations would be important in terms of exercise benefits. Certainly glycemic control, lung health, and endurance are all important to you. And there was just about 8 years ago structured, randomized, controlled intervention looking at aerobic and resistance exercise training programs, a 12-week intervention for 3 days per week. And they did show improvements in glucose tolerance testing as well as pulmonary function and muscle strength. And what I want to highlight here is the significant reduction in the 1 hour, 1.5, and 2 hour plasma glucose, as well as the overall total glucose excursion. So if you look on the left, you can see that the control group, those who were sedentary at baseline, remained sedentary for 12 weeks, had an OGTT at the beginning of that, had an OGTT at the end of that. They look pretty similar over that time. And then if you look at those who completed the exercise intervention, really a nice decline overall in that glucose curve. To the point where we're looking at, impaired glucose tolerance on average in the pre-intervention group, and then in the post-intervention, that 2 hour mark just kind of being around that 140, or really some individuals probably no longer being impaired. So really, I think impressive considerations. And we know that in type 2 diabetes, but it's really nice to see, thinking about all the different mechanistic rationale for CFRD, that does stand. And it was not by increasing insulin excursion. They looked at that as well. It really is improving that insulin sensitivity. So there was an article just a few years ago out of Washington looking at resistance training recommendations for CF and CFRD, and this was the recommendations they provided. So resistance training 2 to 3 days a week, about 10 to 15 minutes for warm-up, and then the sessions themselves lasting 30 to 60. And they provide other parameters as well that you guys probably know a lot better than I do. That article did not provide aerobic training recommendations, so I wanted to share this as well, that came out of the American College of Sports Medicine. Aerobic training recommendations for 3 to 5 days a week, progressively increasing from there, and similarly increasing the intensity. A really important consideration for you all is the hypoglycemia that can occur before, during, after exercise. And so some of the symptoms you might see are headache, shaking, sweating, feeling tired, feeling weak, feeling hungry. Some of these patients identify and might bring out at their session. Others, like I didn't see irritability on this diagram, and I think that's something that we'll often see with folks that are hypoglycemic and might not be identifying hypoglycemia, but you might notice that behavior change. So really important to keep that in mind. Those who are on insulin have increased risk for exercise-induced hypoglycemia, and so we usually target a blood sugar above 100 before exercise for those on insulin. Giving carbohydrates before exercise if trending low can be important. Decreasing insulin with the meal prior can be a potential way to avoid this. Consuming carbohydrates during exercise can be important, and of course, in the clinic setting or in the gym setting, keeping juice, sports drinks, glucose tabs handy to treat a low blood sugar as needed. Lots of patients now with diabetes are on some sort of technology, continuous glucose monitors being pretty common. And this is really helpful for us on the endocrine side to really be looking at the specifics of what's going on during the exercise sessions and how we can kind of customize plans for individuals. But what I wanted to highlight for you all is that CGMs are looking at your blood sugar over time, but they're measuring from the interstitial fluids and not capillary blood sugar, like you would do with a finger stick. And so their blood sugars are moving like a roller coaster, and CGM is kind of that back car on the roller coaster. So you're not picking up the blood sugar of that exact second. It actually is about 5 minutes behind. And so if you are treating somebody for hypoglycemia, you're giving juice, you might not see the improvement right away on the CGM itself. And so if you're trying to get back into exercise, checking in 15 minutes on a finger stick can be helpful for getting people back to exercise without continuing to overtreat with simple carbs, which can, have their own not great effects. In terms of automated insulin delivery, just wanted to share, our updated technologies and what you might see with patients. So the CGM information that I just mentioned can communicate now with various different pumps, insulin pumps, and really automate how much insulin they're getting based off of what the pump is seeing in terms of blood sugar trends. The main thing that's been studied in CF is the bionic pancreas. And you'll see in this purple dashed line, 70% time in range is what our goal typically is. For those in usual care, you can see that it can vary dramatically. Those on the bionic pancreas really tightened up, and then the average is above that 70% time in range. But really importantly, too, is how that impacts hypoglycemia. So because this is able to look at your blood sugar trends, it can help prevent hypoglycemia as well. So you can see that those larger circles on the left are not as large on the right. Also for you to be aware in these various sessions, certain pumps like Omnipod 5, Tandem with Control IQ, the Medtronic 670 and beyond have exercise modes, which can set temporary targets. So that's an option before exercise that can prevent needing to give as many carbohydrates. But also really, really important, something I see a lot is needing to be cautious with pre-dosing those carbs. So those recommendations I gave before are not necessarily for somebody who's on automated insulin delivery. What you can see if you have a large carbohydrate load when you're on automated insulin delivery is a really quick rise in the blood sugar. And then the pump, it's so brilliant, is like, how can I get this down as quickly as possible? And then you can see reactive hypoglycemia. So really needing to understand just like how those pumps are working so that we're not treating patients incorrectly. If they're not on automated insulin delivery, if you can't change to exercise modes, some options might be suspending basal insulin and untethering the pump during exercise. And so really understanding what your patient's current treatment plan is, what type of pump they're on, what that's doing in the background can be helpful so that you can collaborate with them, collaborate with their endocrine providers, the nutritionists on the endocrine team, et cetera, to really help come up with a customized plan for that individual. I think I only have just a moment, but I just really quickly wanted to highlight glycemic changes in the era of highly effective modulator therapy. So with PROMISE, we saw a small but statistically significant improvement in A1C, but not much change in glucose tolerance. But it also didn't deteriorate. So this was published in JCEM, and then I see that there are a couple of prospective ETI studies out of Milan that are posters today, so you can check those out. But overall, it seems like ETI, at least when it started in the older age groups, is unlikely to make prediabetes or diabetes go away, but maybe it's helping kind of prevent deterioration. BEGIN is looking at children under 6 years of age and has the advantage too of using continuous glucose monitors. But I think right now what they seem to be seeing is dysglycemia, and it's hard to, without good comparisons to control populations and what happens with a typical 5-year-old, what do their blood sugars look like. But you can check that out at poster 677. And actually this afternoon's symposium on modulator therapy, Kevin Scully will be talking about that in more detail as well. Overweight and obesity is a big change and opening the possibility for medications for metabolic syndrome in CFRD. So there are clinical trials ongoing for non-insulin therapies, things like DPP-4 inhibitors, GLP-1s, what you hear of a lot in terms of things like Ozempic, which is semaglutide. There are posters on that, 684 and 687, SGLT2 inhibitors and other dietary modification. The GLP-1s augment our insulin secretion after a meal, can increase satiety, have potential beneficial kidney and cardiovascular effects, but can also delay gastric emptying, which is, I think, a question mark in CF and how that could impact our patients. This is just registry data showing, the increase in overweight and obesity in youth as well as adults. And then the most recent 2024, again, is not released, but from the highlights, you can see that between 2004 and 2024, an increase in pediatric overweight and obesity from 10% to 21%, and for adults from 18% to actually 43%. So definitely, you might see changes over time in terms of our ultimate CFRD recommendations. So I think important things are personalized approaches to CFRD screening and diagnosis, interventions to delay or prevent CFRD, these non-insulin therapies, better tools and technologies, really thinking about the patients and their treatment burden, better understanding what our targets are, and increase access to endocrinologists, which is why I'm very grateful for the Envision program and what it's offered to me, as well as many colleagues, as you can see here. So CFRD is certainly common and impactful. Treating CFRD is beneficial for lung health and function. Exercise is beneficial for lung health and CFRD, and really all of this is interrelated. So I think that really good team communication, multidisciplinary support are crucial. I'm very grateful for my CHOP CF team and our CHOP CF endocrine team, as well as the CF Envision program. So thank you all for your attention.
We have one question. An earlier talk suggested that the OGTT was not necessarily the optimum way to track glucose and perhaps A1C was the better choice. What is your feeling on this based on the impact glucose can have on lung function?
Yeah, really, really great
good.
question. I think in terms of our optimal screening, I would say that often what we're seeing, and actually let me go back to that image of the continuous glucose monitor, because the challenge with an A1C is that it's really picking up your average blood sugar more or less over 3 months. And so you're not capturing glycemic excursions. I mentioned that in CFRD, there isn't always fasting hyperglycemia at the start. A lot of what we see is the postprandial excursions. And so if you look at an average of this blood sugar, you might come up with a more normal A1C than what actual glucose variability you're seeing for the individual. So generally, I would say that the OGTT is a better test for glycemic excursions, a better understanding of what's going on for that individual. And I think CGMs can also be really helpful in terms of understanding what's going on in daily living and not a 75-gram load of pure sugar. But there's a lot ongoing in terms of understanding CGMs better and whether at some point those can be more utilized for screening.
I have a question. So, and I think you touched on this, but the impact of highly effective modulator therapy on CFRD, are you seeing any potential resolution?
So we're definitely not seeing resolution for those with CFRD. Maybe, like I was saying, some delay, like not progressing, not deteriorating for those who are in earlier stages. I think it's similar to what we've seen with a lot of other comorbidities of CF in response to modulator therapy, that a lot of the damage is done before we've been able to implement modulator therapy. And so over time, I hope that that's what we'll see as there's earlier and earlier intervention. And now we're seeing cases of in utero exposure to modulator therapy. So I hope at some point, yes, but right now we're not seeing necessarily resolution of CFRD. I've had to update some insulin dosing on some patients, those sort of things, but no resolution, unfortunately.
Are there any other questions? All right, thank you.
Thank you.
Our last speaker is Blythe Owen, a physiotherapist who has been practicing for more than 2 decades at the Hospital for Sick Children in Toronto, Canada. She's a passion to work with children and has worked in general pediatrics, respirology, lung transplant, and intensive care units, as well as an ambulatory setting for patients with chronic lung conditions. She's involved in clinical and academic teaching and is status-appointed lecturer at the University of Toronto. She's the co-author for the chapter on cystic fibrosis in the textbook, Physical Therapy in Children. She contributed to CF Canada's guidelines on inhaled antibiotics and was the recipient of Ontario's Outstanding Healthcare Provider Award for Cystic Fibrosis Canada in 2021. Please welcome Blythe Owen.
Good morning, and thank you for that very warm introduction. Thank you all for attending this session. I will be talking about challenges of caring for people with cystic fibrosis not eligible for modulator therapy. Disclaimers, and disclosure slide. And so my objectives really are to share some lived experiences of case studies of persons living with cystic fibrosis not eligible for CFTRs, and also some of those challenges faced by people in that category. So I'll present 2 case studies as well as look at a short literature review and go over one of the articles that I came across. So in terms of accessibility of CFTR modulators, worldwide, 82% of people diagnosed with cystic fibrosis have at least one copy of that F508 del, and thus are eligible for ETI. However, 80 to 90 proportion of the F508 are actually found in North America, Western Europe, and Australia. And so if I bring your attention to this map, we can see the green areas, and that's where ETI is actually accessible and funded, and people with CF have access to it. When you look at the red regions, those are the ones without access to ETI. And some of those factors may include social determinants of health that directly or indirectly impact cystic fibrosis outcomes through their policies, socioeconomic status, as well as race and ethnicity as well. But I also want to mention that there are people with cystic fibrosis who don't tolerate the ETIs or highly effective modulator therapies, and that there is lack of funding and a lack of access to the medications as well as funding to CFTR modulators. So in terms of Canada, I just want to bring up to speed in terms of when these modulators became available. In 2012 was the first generation of the ivacaftor, followed by 2016 with lumacaftor-iva. 2018 with the triple combination of Tezi, Iva, and ivacaftor. Oh, sorry, it's a double combination. And then Trikafta, the ETI in 2021. And very most recently with the VTD combination in 2025, just in the summer. So I didn't want to forget what some of these common symptoms of CF disease kind of pre-modulators are. And this is an exhaustive list, but I did want to mention that people who are on ETI may still experience some of these, but they may be to a different variability or degree of severity as well. But you've got your GI issues, your respiratory symptoms, mental health issues, as well as chronic pain. And we all know that very high burden of care, 1 to 4 hours on average per day on medical treatments, including pulmonary, nutritional therapies, and not just the daily therapies that they do. Time to make that they have to go for their medical appointments, if they're admitted for hospitalization, things that they have to think about in terms of avoiding germs or not being able to hang out with somebody else with cystic fibrosis. And just those feelings of isolation or being a burden on others. They may have financial concerns, like one of our talks that we heard about earlier today, about the fear of running out of treatments or even being able to afford medications or their insurance coverage. And that has a really big toll as well on their mental health. So what are some of the mental health challenges? What about just their ability to spend time with their friends? Their activity participations? What are some of the sports, hobbies, extracurriculars they would want to be involved in? Whether they're in school or they're working, what are some of the financial stabilities or strains that they're encountering? For adults especially, trying to stay healthy for their dependents. And all of these worries can have an impact on poorer sleep quality, lead to lower self-esteem, as we have heard, higher anxiety and depression with people with CF. And this impacts them on a daily life, both mentally and physically. And they have very many worries about their plans for their future. So the first study I want to present to you is my friend M.A. Who is he? He is a 15-year-old male with cystic fibrosis and pancreatic insufficiency. He had prenatal genetic testing, and that's because his older sister also had CF. He has a class 1 mutation with those lovely numbers, and a SWETA diagnosis of 76 millimoles per liter. He is Southeast Asian in terms of ethnicity. In terms of his social history, mom is the main caregiver. He's got 3 older sisters, and as I mentioned, one with cystic fibrosis. Dad is self-employed, and he works long hours as a computer store owner. During his infant-toddler stage, he was on enzymes, Ur-8X, nebulized salbutamol with saline. His airway clearance included percussion and modified postural drainage, which was done once daily, although it was recommended twice daily. And there was very much wavering adherence, and regular clinic visits were used to reinforce the importance and integration of airway clearance into their daily routine. His microgrew usual flora. He had the intermittent wet cough that would come and go, but no increased work or breathing. A very, very busy kid and very developmentally appropriate. Then we move on to the preschool stage in about 2012. Same kind of routines as before in terms of enzymes, vitamins, and his percussion. But his airway clearance actually started to evolve because he was a bit older. We could add things like jumping on the trampoline with huffing. He was taught TheraPep, although with supervision, and that unfortunately led to lower adherence. By then, his micro showed Staph aureus. Ivacaftor at this point in time had become available in Canada, though the majority weren't actually eligible just yet. So in terms of CFTR modulators, this really didn't come up in the conversation with the family. At the same time, he started to have a few more complications, increased pulmonary exacerbations, and that was likely related to his decreased adherence to airway clearance. By the time he was school age, around 2016, that's when CFTR modulators for the homozygous F508 became available in Canada. Again, that did not apply to him. And at the same time, he started to have some clinical deteriorations with a decrease in his FEV1, wheezing, shortness of breath on shortness on breath on exertion, and he also started to have rising IgE levels. He was not responding to the typical antibiotics, and he was later diagnosed with ABPA. And on micro, he continued to grow MSSA as well as Pseudomonas mucoid type. He was later started on prednisone, and he had an improving clinical effect with IgE decreasing, although he still had some shortness of breath with exercise, and his FEV1 had not increased back to its baseline. And further to that, he developed adrenal insufficiency secondary to the chronic use of ABPA, and he had these recurrent admissions for pulmonary exacerbation as well as weight loss. And I want to mention as well, his sister's health secondary to CF was also declining. So during his pre-adolescence in 2019, a G-tube was inserted for supplemental nutrition, and with a lot of negotiation, he would only use it nocturnally. His sister with CF receives a double lung transplant also in 2019. So you can see these juggling challenges that mom was actually in the hospital with the sister. And so MA was home with his sisters, and they were required to try to help with the supervision of his therapies, his enzymes, vitamins, inhalations. I put the question mark because it was quite difficult to know what degree of supervision was actually provided to MA. We really worked with child life specialists and other members on our team to use strategies such as incentive calendars to try to improve his adherence. And really, it was kind of unfair because it was a very high burden of care for MA, and there was this push for increased independence at such a young age with so many of his therapies. During his adolescence, unfortunately, his sister is admitted for organ rejection, and that was post-double lung transplant. His sister's health continues to deteriorate, and she is admitted to the PICU and unfortunately passes away early 2022. At that point in time, if you notice the timeline, ETI has become available for Canadians age 12 and up, and it is publicly funded. But for his age, he would have met the age requirement. Those genetics were not approved for its use. So we look at the social situation with 2 children with declining health, a prolonged hospitalization for his sister, and these recurrent admissions for MA. He continues to have a decline in his FEV1. So a bronchoscopy was done, and there were new microbial findings, including, Pseudomonas he had already grown, but there was steno as well as the Haemophilus. There was ongoing psychosocial support offered to him from a hospital as well as community perspective, but he really wasn't ready to talk about it, and he wasn't open just yet. So again, CFTR modulators are not on their mind. Here's just a graph looking at his FEV1. So we can kind of see when he was very young, he blew close to 100 in the 90s, but we see this very general decline, and it continues to go down with those dips in terms of all those multiple admissions that he did have. Here's his BMI trend. We can see when he was younger, he was kind of around the 3rd to the 10th percentile with a big increase in his BMI, kind of around 8.5. You can see another big increase at age 12, and that's likely related to when his G-tube was inserted. More recently, you can see that his BMI has really plateaued, if not gone down a little bit. So how is he doing now? In adolescence, he recently did open up and reach out, or psychology continued to reach out, and he accepted being able to talk to them. MA shared memories about his sister, how they played together, the similarities and differences in their CF regimes, and what he misses about her. He didn't display any distress or denied any concerns about his own health. And I remember there was a donated bike to the hospital, and we gifted it to MA. And it brought tears to my eyes when he said in clinic, "This is great. Now I don't have to ride my sister's bike anymore. It was getting too small." It really has helped him, motivate him to develop a passion for biking. He's really into road biking. He bikes to school. Every time I see him, he talks about going to biking with his friends. And he's not a fair weather biker. He'll even bike in the cold weather and in the snow in Toronto. The adherence to his therapies continue to be a struggle, with him missing his inhaled antibiotics recently and performing his PEP therapy just a few times a week. So I've taught him active cycle of breathing in the past, and I continue to encourage it, but more ad lib because right now it's too difficult for him to be able to fit it in, that 15 or 20 minutes post inhalations. Again, the family and MA don't bring up the CFTR modulators or their future therapies, and we really focus on his goals, which are he wants to finish school and go to university. He will be turning 18 soon, so we're really working hard as a team to fulfill his make-a-wish, and he really likes F1 racing or maybe something related to biking. And as we know in pediatrics, we're not just treating the patient, but also the family. So in terms of mom's perspective, she has always felt that she devotes each day caring for her children and managing her home. She was always responsible for all of their medical cares. So we have continued to encourage her to practice self-care as well as taking breaks as part of her coping. But she has identified that prayer and religion are important to her to help her family stay grounded and for her especially to remain positive. Then I want to present a second case study, my buddy named PB. He is a 6-year-old boy with cystic fibrosis. He had meconium ileus and required a laparotomy with the irrigation, positive newborn screening, and he has a class 2 mutation with very high sweat chlorides. He is also pancreatic insufficient, and his ethnicity is Caucasian. On a CT scan recently, it was shown that he had cylindrical bronchiectasis already with some air trapping and fatty replacement of the pancreas. His routine includes a multivitamin, pancreatic enzymes, nutritional supplements. He takes salbutamol, 7% hypertonic saline. His airway clearance consists of modified postural drainage and percussion. He takes an inhaled corticosteroid steroid as well as a nasal spray. He's a pretty active kid, so he loves running, playing at the park, trampoline jumping. Recess is his favorite subject at school, and he really enjoys soccer. His family consists of mom, dad, an older sister, and brother. And some of the different challenges faced by this family is mom is part of a CF social media group. And so when ETI first became available in Canada, she really felt left out. And on top of this, there were all these stressors. There was that complicated history at birth. PB had multiple pulmonary exacerbations, which were often preceded by viral triggers. He had wheezing when he was younger, so they were very high users of the ED as well as their PCP. Mom also identified that she's just tired. The regular, parental fatigue from caring for 3 children on top of the CF cares and all of the infection control. Dad once said to me, coming down to the hospital is so stressful, to have to drive through congested heavy traffic and then to have to see so many healthcare professionals. And at a local CF walk, he also said to me, it's such a relief to see you outside of the hospital environment and you playing with my kid. Mom has a really close relationship with the CF team, particularly the RN. She calls regularly for reassurance of PB's respiratory symptoms and to offload her stresses just from being a parent of a person with cystic fibrosis. Physio has a very close relationship with the parents and child, and we often collaborate with the child life specialist to provide ongoing reassurance, encouragement, and really working through strategies at different ages to improve the cooperation with his respiratory therapies. And so here's a brief picture just looking at his BMI. We can see that it's been quite consistent, quite flat, plateau looking kind of between the 10 to the 25th percentile. And if we look at his spirometry, his FEV1, it's really only been in the past year and a half, but it's super high and super stable. And here's the latest update. As of June 2025, his mutation was approved for the VTD combination with Health Canada, and that Health Canada approved it in July of 2025. I think from a patient and family perspective, as well as our clinic, we're both eagerly waiting the funding status. And I remember as soon as mom found out, she called the clinic, she was crying on the phone with the RN, but it was tears of disbelief, renewed hope, and joy. And so finally, I wanted to end with just sharing a study that I came across entitled Lived Experiences of Persons with Cystic Fibrosis Not Eligible for ETI. It was a qualitative study that includes semi-structured interviews, and it was done in Rome with 13 participants. Open-ended questions were asked, but the general theme was, can you share your experiences and feelings regarding your ineligibility for ETI? And themes were generated. I'm going to share some of these themes. Number 1 was disappointment. All of the participants reported an abrupt shift from hope and enthusiasm to disappointment. But that degree of disappointment may be influenced by their previous enthusiasm from social media, the CF team, or even how others in the CF community felt about ETI approval. There were very intense emotions, ranging from sadness and anguish. One participant stated, although the CF team explained to me why I couldn't have ETI, nevertheless, I remained almost freezing when they told me. Afterwards, it was a big disappointment for me to know that I could not have ETI. When I think of my friends who started ETI, I think they told me for them it was a rebirth. I must admit, I was sorry to not be able to start treatment with ETI. The second theme was information sharing. They felt that communication and disclosure of being deemed ineligible for ETI were very important, and that early discussions with the CF team with good communication and educational support needed to be implemented. Number 3 was happiness, but it was very interesting. It was a selfless happiness. Happiness for other people with CF to get a breakthrough, but then they felt like they were just going back to their lives. And they weren't sure if this was an altruistic sense of community or it was to balance their own negative emotions with what was more socially desirable. Some felt happy and excited, but others also reported conflicting feelings such as bittersweet, envious, sad, frustrating, disappointing, angry, worried, and left behind. They felt the psychological intervention could offer an opportunity to identify, validate, and adjust their expectation, especially if it's somebody who has more difficulty tolerating disappointment. And then the fourth theme was some of their concerns. They were health concerns because day by day, they felt like their disease continued to worsen. In fact, one of the quotes said, I think about what can happen to me. I know that my illness gets worse day by day. I see it every day. I don't even want to say it, but sometimes I think about my death. And finally, an uncertain future. There were kind of two spectrums of it. There was that lack of hope. Some reported deterioration in their mental health, including increased anxiety and depressive symptoms, as they felt very frustrated due to limited expectations in their future. Whereas some felt that there was continued hope, there was trust in advancing medicine and research, and that they could play an active role in this research pushing it forward. So the overarching goal really is to have a partnership between the CF basic scientists, clinical investigators, biopharmaceutical companies, advocacy organizations and regulators, and the community to ensure that therapies are developed timely and are accessible for all. And so what does the future hold? We've seen from this conference that there are many exciting things going on, CF fit studies, personalized medicine, mRNA, small molecules, and lipid nanoparticles. And we all have been practicing this holistic approach, and I don't think any of that would continue to change. So in terms of discussion or questions that we can talk about are, what are some of the unique challenges that you have encountered in your patients who aren't eligible for CFTR modulators? What additional supports can we provide these persons with CF? And in many parts of the world where CFTR modulators are not available or not funded, what do you tell your patients and families? Finally, I just want to acknowledge the NACF Planning Committee, as well as our great moderators, Kim and Dawn up here, all of you attendees, the patients and families I work with, the SICKID CF Clinic, and the Physiotherapy Department. Thank you very much for listening.
Do we have any questions for Blythe? Blythe, I have one.
Sure.
Does your center make it a regular practice to educate your families and patients about ongoing research, evidence-based medicine, just, I don't want to say to provide hope, but so that they don't feel hopeless, like that somebody is working on trying to advance therapies that would make them eligible or that they would be eligible for?
Mm-hmm. I don't think we have a structured process in place necessarily, although I think that there is a lot of discussion, especially now with things being at people's fingertips to look up things on the internet, that families are often coming to us with questions. Usually our doctors are very informed about new papers that come out, but it's pretty alarming that, you know, within a day of publication of an article, patients and families already know about it.
We had one, just quick, we had one situation where we had a family with 2 children with CF that were heterozygous F508del. And for so long, they were hanging on the next medication that was going to be approved, hoping that their children would be eligible. And in fact, when 2019 came, and her children were very sick and often admitted, 2019 came, she came into clinic. They were informed, she knew that her children were now eligible for Trikafta. She cried. Mm-hmm. And we were all like, is this a happy cry? She said, no, it's a very sad cry. I'm happy for my children, but I also know how that other 10% feel.
Yeah, that's very real.
All right, any other, oh, go ahead.
And this is why we do what we do. Thank you very much.
Thank you.
Really quickly, before everybody goes, I just want to end this session with an acknowledgement of my co-moderator, Kim, for coming up with this great idea to look at comorbidities and other things that will challenge us as respiratory therapists and physical therapists. I hope this was a learning for everybody. If you do have any ideas for future presentations for this session, please email Kim or I. We're always looking for ideas. And thank you all for coming. I thank our speakers. They were wonderful presentations, and enjoy the rest of the conference.